Today we'll speak about miscarriage. Definition of miscarriage is the spontaneous loss of a fetus before 20 weeks of pregnancy. Pregnancy loss after 20 weeks are called stillbirth. Causes of miscarriage. The following factors are associated with increased risk of miscarriage, like chromosomal abnormalities, which is the single largest cause of sporadic miscarriage. It represents about 50% of cases. Fetal malformation, other than those which are caused by chromosomal anomalies. Placental abnormalities. Infection. Several organisms have been associated with miscarriage, like listeria, toxoplasmosis, herpes, varicella zoster, and malaria. Maternal and paternal factors like multiple pregnancy, advanced maternal age, advanced paternal age, stress, including the number of stressful or traumatic events, previous termination, low pre-pregnancy body weight, change of a partner, previous miscarriage, infertility, assisted conception, chronic illness, thyroid disorders, and uncontrolled diabetes, trauma, radiotherapy and chemotherapy, uterine malformations and fibroid, high maternal body mass index, high alcohol consumption, heavy bleeding, general anesthesia during early pregnancy. And there are other factors which are associated with reduced risk of miscarriage, like previous live births, nausea, vitamin supplementation, eating fresh fruits and vegetables daily. As there are factors which has no evidence or association with miscarriage, like caffeine consumption, smoking, moderate or occasional alcohol consumption, educational level, socioeconomic status, and walking during pregnancy. For clinical picture of miscarriage, usually it presents with pain and bleeding. Types of miscarriage. First type is threatened miscarriage, in which the patient complains of pain and bleeding, but the cervical os is still closed, and by ultrasound there is still a live intrauterine pregnancy, so it's called as threatened miscarriage. Missed miscarriage, in which the patient may or may not have pain or bleeding, but the ultrasound scan show absent fetal heart pulsation. Complete miscarriage, in which a patient presents after a history of pain and bleeding, but at the moment the pain is mild and the bleeding is settling, and by examination cervical os is closed, and by ultrasound you find the empty uterine cavity. Opposite is incomplete miscarriage, in which the patient presents after a history of pain and bleeding, but still she is suffering from pain and still bleeding is ongoing. By examination you will find cervical os open. You may find retained product of conception coming out of cervical os, and by ultrasound you find retained products. Septic miscarriage occurs when an infection supersedes any type of miscarriage, either missed, incomplete, or the illegal abortion, and is complicated by infection and can lead to septic shock. Ultrasound is the main diagnostic tool or modality to assess miscarriage. So by TV scan, if you find a gestational sac with no fetal ball and the sac is less than 25 mm, you need to repeat in 7 days. But if the sac is equal or more 25 mm, then you either obtain second opinion to confirm an embryonic pregnancy or repeat in 7 days time. If you are using a transabdominal ultrasound scan, then you have to record gestational sac size and repeat in 14 days. However, if you find a crown lump length by transvaginal scan with no fetal heart, so if the size of the crown lump length is less than 7 mm, then repeat in 7 days time. But if it is equal or more than 7 mm, then you need second opinion or repeat in 7 days time to confirm miscarriage. But by transabdominal ultrasound scan, if you find a crown lump length with no fetal heart, then you have to record the crown lump length size and repeat in 14 days. Take care when diagnosing a complete miscarriage on an ultrasound scan. In the absence of a previous scan confirming an intrauterine pregnancy, always be aware of the possibility of pregnancy of unknown location. Advise these women to return for follow-up, either by beta HCG levels or ultrasound scan, until you have a definitive diagnosis. Management, we have 3 management options, either expectant, medical, or surgical. And surgical can be done in one of 2 ways, either manual vacuum aspiration, which can be done in the outpatient setting, or evacuation of retained product of conception, which will require anesthesia. So expectant management is usually the first line for women with a confirmed diagnosis of miscarriage. It can be done up to 14 days. However, the woman must be counseled about all her options and must be counseled to seek advice if there is increased hemorrhage, because expectant management carry a risk of increased hemorrhage, especially if she is in late first trimester or she has a previous adverse or traumatic experience like stillbirth, previous miscarriage, previous antepartum hemorrhage, or in case of anxiety. Also, women should be counseled about risk of infection. If the woman chooses to have expectant management, then we have to repeat the urine pregnancy test after 3 weeks. And if it is still positive, we need to offer her ultrasound scan and discuss other management option. However, offer a repeat scan if after the period of expectant management, the bleeding and pain haven't settled. This suggests that the process of miscarriage hasn't begun, or there is a persistent pain and bleeding or increasing, which may suggest incomplete miscarriage. Review the condition of women who opt for a continued expectant management of miscarriage at a minimum 14 days after the first follow-up appointment. Medical management of miscarriage. Don't offer mifepristone as a treatment for missed or incomplete miscarriage. Offer vaginal misoprostol for the medical treatment of missed or incomplete miscarriage. Oral administration is an acceptable alternative if it is the woman's preference. Single dose of 800 mg of misoprostol. Advise the woman that if bleeding hasn't started 24 hours after treatment, she should contact her healthcare professional to determine ongoing individualized care. In case of incomplete miscarriage, you can use single dose of 600 mg misoprostol. 800 mg can be used as an alternative to allow alignment of treatment protocols for both missed and incomplete miscarriage. Offer all women receiving medical management of miscarriage pain relief and antiemetic as needed. Inform women undergoing medical management of miscarriage about what to expect throughout the process, including the length, extent of bleeding, potential side effects of treatment, including pain, diarrhea, and vomiting. We have to take urinary pregnancy test 3 weeks after medical management of miscarriage. If it's still positive, she needs to return back for review by a healthcare professional to ensure that there is no molar or ectopic pregnancy. For surgical management of miscarriage, we have 2 options as we said before. We have either surgical management in theater under general anesthetics, which we call it evacuation of retained product of conception. We have manual vacuum aspiration under local anesthetic in outpatient or clinical setting, in which the patient can have the procedure while she's still awake. We inject local anesthesia in the cervix. We have to infiltrate the 4 quadrant to make sure that the patient is completely comfy, not feeling pain. Patient should be counseled throughout the procedure because she's awake, so she should be counseled about what she is expecting in order to achieve the full confidence of the patient in the procedure. You have to be gentle to avoid any pain. And patient should be counseled that in event of incomplete evacuation, we need to go for surgical assessment under anesthesia. Thank you.